Nederveld is an internal medicine pediatrics trained board physician who lives and works in Grand Junction, Colorado. She's assistant professor in the Department of Family Medicine here at the Anschutz campus. And she's committed to primary care research that improves the health of individuals and communities by establishing cross-sector understanding and collaboration. She's particularly interested in prevention of chronic disease through behavior change, and she practices at a federally qualified health center and directs the Western Colorado PBRN, or PeachNet. She'll be followed by Heather Bleacher, and Dr. Bleacher is core faculty in the University of Colorado Department of Family Medicine residency. Since 2012, she has co-directed the residency's community health curriculum, which focuses on population health, advocacy, and community engagement. She practices full-scope family medicine in Denver, Colorado, and has led initiatives at her practice to address patients' social needs during clinical encounters. Her guiding intention is to continually work toward health equity with interests focused on social determinants of health, primary care and public health collaboration, and health literacy. And finally, we'll hear from Amy Huebschmann. Dr. Huebschmann is an associate professor in the University of Colorado School of Medicine with the Division of General Internal Medicine and the Center for Women's Health Research. She's funded by a K-23 Career Development Award from the National Heart, Lung, Blood Institute and the National Institutes of Health, and was previously funded by a KL2 award from the Colorado Clinical and Translational Sciences Institute. So we'll hear from the three of these presenters. And I'm learning that Anne is having trouble to get in. So Heather, if you don't mind, we're gonna start with you and we'll move to Anne next if she's able to get in. And if you have questions along the way, please feel free to put them in the chat box. We'll be monitoring that along the way. And when we've heard from all three of them, I'll jump in, do a little summary, and then try to field questions. If you have questions you really want to ask yourself, please feel free to use the raise hand in the participants section. So both chat and participants should be along the bottom of your view. So without any further ado, we'll move to hearing from Heather Bleacher.
All right. Hi, all. Can everyone hear me okay?
We can.
Okay, perfect. So let me get my slides up.
There we go.
All right. And so I will give the disclosure that my home office has no door and I have small crazy children running around. So if there's anything you can't hear because of shrieks or squeals, let me know. So diving into things, I practice at the A.F. Williams Family Medicine Clinic in the Stapleton neighborhood of Denver. We are a continuity clinic site for the family medicine residency, and we're a fairly big, complicated clinic. We have 24 faculty, 20 residents. We see over almost 40,000 patients per year. We were the first clinic in the UC health system to adopt the APEX model. And for those of you who aren't familiar with that, the main thing to know that's pertinent to this presentation is that our medical assistants function at a very high level and can perform a wide variety of functions and tasks. And we have a very robust integrated care team, including behavioral health, pharmacy, a care manager, part-time social worker, and then some volunteer patient navigators. So the high-level overview of our social needs screening pilot is here. We first decided as a clinic to start screening for social needs in December of 2015, and for a variety of reasons didn't actually begin the screening until November of 2017, which is a very long time. That happened for a couple of reasons. One is there are a lot of details to figure out when implementing a program like this carefully and in a way that is sensitive to patient needs and trying to reduce stigma. We also had some very large competing projects going on at the clinic that pushed back our timeline. So over the 9 months of the pilot, we screened about 2,000 patients. 541 of those reported at least one social need, and of those, 146 patients asked for assistance from the clinic. We are not currently screening in a very robust way at this point for a couple of reasons. One, the screening questionnaire that we had been using was removed from the electronic medical record, so we had no way to document the questions we wanted to ask, and so we needed to transition to the new questions, which we weren't as comfortable with. And the second piece was that UC Health started plans to implement social needs screening system-wide. And given all the work that it took to try to get our screening off the ground and running, we didn't think it was fair to put all that effort on our staff, knowing that things would change soon. So we had a small grant from the Clinical Effectiveness and Patient Safety Program here at the CU School of Medicine. So we were able to do a little bit more of a robust evaluation, but this was no way meant to be a true research study. We looked at process questions such as what proportion of patients were actually getting screened, who should have been screened. We were looking at who got screened versus who should have been screened. We asked our staff and providers about their attitudes, as well as some implementation related questions, and we looked at the needs that our patients were reporting. We totally failed in our outcome evaluation. We tried to get a report on the number of social need referrals that were replaced in response to social need screening, but I don't even know if that report exists. We just could not get our hands on that. And we tried to survey our patients who were screened afterwards to find out how often needs were being met, and our response rate was terrible, and we ended up having to scrap that. So this is the screener that we ended up using. We cobbled it together from a variety of different sources, and you can see the different domains that we asked about there on the slide. We chose the domains that we asked about based on how relevant were they to clinical care, how able were we to intervene on them, and honestly, related to how short the question was. We wanted this to be a minimum burden on our patients, and we really wanted it to be on one sheet. How did we do the screening? So first of all, we chose what populations we wanted to begin to screen. We were screening new patients and patients presenting for preventive care, and this included our adult and pediatric patients. When they checked in at the front desk, they were given a paper screener. We chose a paper screener because research has shown that patients are more likely to disclose social needs if it's written or on a tablet as opposed to reporting things verbally. When the patient completes the screener, they give it to the medical assistant who enters the results into the electronic medical record. If the patient reported a social need and wanted assistance from us, the medical assistant would get a social work order ready and then would communicate results to the provider and ideally, in a perfect world, to the social worker, hoping that they'd be able to meet with the patient right then and there. We really worked to make the provider's role pretty minimal in all of this. The only thing they absolutely had to do was sign the order for social work. But of course, we hoped that they would be aware of the screening results and use them in a way that was meaningful for them and the patient in their clinical care. And then what typically would happen is that our social worker or our patient navigator would call the patient after the visit to try to connect them to resources. And this was certainly one of the barriers that we encountered in terms of being able to get a hold of patients. So as much as people are able to meet face-to-face with patients to try to tell them about what we can offer, I think that really helps. So we tried to do more than just hand people a phone number when we were referring them to community organizations. So we tried to develop relationships with a variety of different community agencies. I'm going to highlight the relationship with Hunger Free Colorado. They are a statewide hunger relief organization. They have a statewide database of food resources. They're also able to screen and begin the enrollment process for SNAP, formerly known as food stamps. And they also were able to send us a monthly data report of what happened with all the folks that we referred to them. So we really enjoyed having that bi-directional communication and not placing the burden on the patient to call for the resource. So this slide looks at the weekly rates of screening. So we looked at how many patients should have been screened and what proportion of them actually got screened. I'm not going to go box by box on this for you, but the main themes and the main types of interventions that we tried during each of our PDSA cycles include communication. So we would do emails, we would do presentations, we would do training to remind people that we were doing the screening and how it was done and why this was so important. Data was an essential one. Once we got our data report, we started sharing that in our morning huddles so that all of the staff who were caring for patients that day knew how well we were doing and could talk about how to improve things. Accessibility of the screener was another big one. The front desk was ultimately responsible for handing out the screener, but we found that when we had the screeners available first in the clinic pods and then finally in the clinic rooms, in the exam rooms, we were much more successful at getting them in the hands of patients. And then the big thing, you can see here at the end, when we started providing weekly emails with provider level data on screening rates, I think a little bit of friendly competition and shame goes a long way to getting people to act. So who was screened versus who should have been screened? The big things I want to draw your attention to were our screening process. We found that we were under screening our patients with public insurance. We also found that we were under screening African American patients as opposed to over screening our Caucasian patients. And I think it's really important to look at this kind of data because, part of the intention behind this sort of pilot is to act on health inequities. And you really have to be careful that the systems that you set up don't actually end up propagating inequities. So we were really glad that we looked at this. So what needs were patients reporting? So as I said, 541 of our screened patients reported at least one need. And this slide is showing what proportion of those 541 patients reported each need. The bar in total shows you the number of patients or the percentage of patients reporting that need. And then the orange bar shows what proportion of those patients actually asked for assistance from the clinic. So financial strain was our most common need. So how hard is it to make ends meet? This was followed by social isolation, which relates to having someone that you can call on if you need assistance. And then behind that was food insecurity and housing problems. And what you can see is that really the rates of people asking for assistance with these needs was very low. And that was definitely a challenge for us to feel like we were actually helping. I mentioned staff and provider surveys. We were very pleased to find that when we asked at the midpoint and the final time periods of the pilot, that most staff and providers did not find social needs screening to be an extra burden. And then when we asked them, well, even though it takes extra work, should we continue using the social needs screening questionnaire? And there was no question that the majority of staff and providers thought we should continue to do it. So we were very happy because, as I said, it was a lot of work to try to get this going. We asked for their input on what they liked and how to improve things. We overwhelmingly heard that this was very eye-opening for staff and providers, and they were so happy that we could uncover these needs and try to help. Things that they suggested we could work on. A big thing was rephrasing the questions. There's this tension between using questions that were developed in research settings and trying to have them be patient-centered. And they were picking up on that and really felt like some of the questions were worded in a confusing way. They suggested having patients complete the screening in the exam room. They said that this was one of the first things to go when we got busy. Providers wanted to make sure they were getting the results of the screener. And a lot of people said they wanted us to open this up so we could screen more patients. So I am not going to go through this point by point. You will actually have this emailed to you afterwards. But the leadership team who worked on this screening pilot tried to identify what were the key areas that clinics trying to implement this kind of project should think about based on our key lessons learned. So, one thing is it just takes a lot of time to figure out all the details. So make sure that you plan for that. Having data and a plan for ongoing PDSA cycles is critical so that you can figure out, well, is the screening actually happening? How can we improve that? And trying to figure out if groups are being excluded from screening. Another thing that we thought is patients around what the screening is all about and how we think we can help would have hopefully helped with uptake of assistance. So my final slide here is just to encourage people and urge people to think beyond just screening and referral. And last fall, the National Academies of Medicine published this great report talking about how we can incorporate social care into healthcare, and beyond the screening and referral, which is this assistant quadrant of activities that can be done. They brought up these other things. So, how can we modify clinical care in response to social barriers? There's a lot of conversation about, well, we shouldn't screen if we can't do anything about it, but that is a little bit limiting, right? If you don't know about patients' social barriers, it's hard to make care plans that work for them. The other group of activities that I think is overlooked often is the advocacy piece, right? So people are very intimidated to ask questions about housing or things that they can't do anything about, but it's impossible for us as the healthcare sector to advocate on behalf of our patients if we don't know the challenges that they're facing. So my final thought is, how can we all get creative and think more broadly than just this identify a problem and fix it mentality that's really common in clinical care? And with that, I am done.
Oh, thank you, Heather. And I believe Anne Nederveld has joined us now. So Anne, if you're ready, we will move to your presentation.
Sure. Right, let me just share it.
And just a reminder to everyone else, if you have questions, please feel free to put them in the chat. And when we get through all three presentations, feel free to raise your hand if there's questions you really want to ask. All right, go ahead, Anne.
All right, so I'm going to talk about the processes we're following in Western Colorado and some research results. So we'll go ahead and get started. So I think people may or may not know this, but the whole region really of Western Colorado is participating in the Accountable Health Communities model through Rocky Mountain Health Plans. And so for people who aren't familiar with that, it's a project through the Center for Medicaid and Medicare Studies, and is involves 30 sites across the country too, or in Colorado. So those of you on the Front Range might be familiar with the Dr. Cog project. Ours is obviously that dot toward Western Colorado. And we are using the HCM screening tool. And the basic tool screens for living situation, food, transportation, utilities, safety. And then there's several supplemental questions people can choose. And I'm just going to show you guys that, form so you can see what the questions are. I did have it pulled up. Sorry, I'm a little flustered. I couldn't get into the Zoom meeting for some reason. I thought I was an imposter, but well, it doesn't seem to want to let me share that. So we'll go back to my other presentation. But basically the questions there, they use the validated food insecurity tool, the 2-question tool, and then they use validated questions for all the other domains. And what the project overall gave the choice for any of the supplemental questions. And Rocky Mountain Health Plans decided to look at the one on social isolation and loneliness. Partly just the geography out here might lend itself to people having more isolation and loneliness. And we also have a high suicide rate in Western Colorado. And so it was felt that that would be a useful question to add to the screening. So there's 6 domains that they're screening for. Really, I think these were chosen for HCM in general because they may be ones that are a little easier to address, not across the board. Obviously, in some of our rural areas in Western Colorado, especially, the needs for better housing and transportation are not easy to meet because we just don't have those resources in all the communities that are doing the screening. At this point, there are more than 50 practices or systems participating across Western Colorado, and they've done over 24,000 screenings as of the end of 2019. They put out this data every 3 months, and I haven't seen the most recent data, but 24,000 at that point, and of more than 15,000 unique patients. So some people have been screened twice now through this project. And now my computer doesn't want to let me move forward. There we go. So this so far is what we're finding as far as percent of individuals screened with each social determinant of health need. And this graph is actually comparing it to the Dr. Cog screening project. So you can see that blue is the Rocky Mountain Health Plan screening data, and orange is Dr. Cog. In Western Colorado, we have higher needs in all of those areas. It's percentage of people that screened positive. So you can see especially food insecurity of people screened was about 43%, compared with 22, I think that is, for DRCOG. So lots of the issues in Western Colorado, at least among the population that we're screening, show higher percentage of need. And then DRCOG is not screening for isolation. So it doesn't mean that no one is isolated in the area that they're screening, just that they're not using that question. So as far as translating screening to resources and action, I think it's interesting the way that Rocky Mountain Health Plans approach this. They're really letting practices do it according to what works for them, which is, you know, good for sustainability. Most practices have a care manager or coordinator that helps to connect people with resources. People may or may not know that we have also had a lot of practice transformation work out here in Western Colorado. So many of the practices that are participating in this screening project also participated in that and already had a system for care management or care coordination. So typically that's the person that's helping to connect people with resources. Rocky Mountain Health Plans itself does a patient navigator program. So for people with really high need, and they determine that based on ER visits and a couple other factors, they will actually help the practice to make sure that that person is connected with resources they need. And then the other thing that we have going on in Western Colorado is information exchange platform. It's not actually totally live yet. They're just doing some beta testing, but it's called the Community Resource Network. And the idea is that it will be an information exchange between community-based organizations or social services and practices with an interface that patients can also access to make these kind of referrals and track that social determinants data, along with other things like who the patient support system is, if they're seeing behavioral health and that kind of thing. So that's supposed to start in the fall and is intended to be a way to refer for social needs, and then also to close that loop with communication back to the practice about whether patients were able to access resources or not. It's been delayed just because I think most projects like this, you know, don't follow their timeline and run into problems with building their product and all of that. And then I'm not sure how the pandemic is necessarily affecting that, but that is soon to be something that we'll be able to use. That will start in Mesa County and then expand outward to most of Western Colorado, hopefully over the next few years. So as far as barriers to screening and also meeting people's needs, these are sort of what we've found. And I missed Heather's presentation, so I'm not sure if these are similar, but so we really see that it's been tough for Rocky Mountain Health Plans to get practices on board, partly because they are not compensating practices at all, which I think the decision was made to do that because they wanted to make this something that would be sustainable and didn't depend on additional funds, but it has probably kept some practices from deciding to go ahead with the screening project. Community level, there's definitely some concern in some of the organizations about resource capacity and availability. So both can existing community-based organizations or resources handle the increased need, especially in areas, you know, that are more rural? And then do they even exist? You know, like I mentioned, some of these areas that are doing the screening, you know, there's not a housing authority. There's not necessarily even a good way to supply food to people who are food insecure. So that's a problem that we're struggling with in Western Colorado. And then at the patient level, patients sometimes are hesitant to answer questions. Culturally in Western Colorado, I think people are kind of a live and let live mentality. And so sometimes patients find these questions strange or intrusive. In some research that we've done out here, we've found concerns about what revealing, for example, food insecurity might mean for involvement of child protective services with your family. So there are concerns among patients and community members about screening. And then there's also a high level of people who decline services outright or may say, yes, please contact me, but then are lost to follow up either because they just don't respond or because phone numbers change. You know, people use temporary addresses. They might not have their own home, so they're staying with someone and then they move on to another place. So lots of issues in that respect. So also with regards to the research that we're doing out here, another big barrier that we've uncovered is stigma. So Elena Broadus and I, she's also, I think, listening here, but we have been working on a project really looking at perspectives on food insecurity across 3 groups, and that's medical providers and staff of practices, community-based organization or social services staff, and then community members. And the research was intended to look at perspectives on data sharing, but we really found some evidence of bias and stigma as far as even using services, and especially within group bias and stigma. And then interestingly, provider lack of awareness of stigma. So, you know, providers kind of not necessarily understanding that people in poverty and with social needs experience some shame and stigma around having to talk about those needs or asking for assistance. And that may have to do culturally, again, with kind of the pull yourself up by your bootstraps mentality that we tend to have out here. But it's been very interesting. One example is in a survey we did, we asked for people to kind of react to different reasons why someone might be food insecure. And community members and social services staff were much more likely to say that something like laziness or lack of responsibility was a cause of food insecurity. And healthcare providers associated it more with lack of knowledge, like how to budget and buy nutritious food and cook with a lower income. And I just want to clarify that the reasons we had for food insecurity on our survey all actually came out of our qualitative data. So we had done several interviews with people in these 3 groups, and these were the things that people told us they thought caused food insecurity. So we were not trying to put the idea that laziness is behind food insecurity in people's minds. It just really came out in the qualitative data. So just to give you an example of this, so one quote from a provider was, "It's like pulling teeth to get people to talk about this. I don't know if there's so much stigma. They're worried that a doctor is going to judge them because they're eating too many cookies and chips." So this provider felt like, you know, people didn't talk about not having enough to eat or didn't want to talk about what they ate because they weren't eating healthy food, not because they were having trouble affording the food or they felt stigmatized. And then a community member quote is, "I've gotten dirty looks myself in the grocery store checkout line, and it just makes me feel like less of a person. They see that I'm using food stamps, the SNAP card that I have, and I sometimes get a little side glance, like, really, does she need that?" And we had numerous quotes like this, and just about people on social media feeling stigmatized if they asked for any help, and really in all areas, from staff working in these organizations, et cetera. So the response for us, as far as, you know, what we found and what we're moving on to continue to examine in the second phase of this research, we're looking at what providers and school staff know about the lived experience of people with social needs, and especially really trying to explore their understanding of stigma and how that might affect what people tell them, their discussions with people, and whether they're ultimately able to help address any of these needs. We'll be using a user-centered design process to design some kind of intervention that hopefully will increase awareness of the lived experience among providers and school staff, and then we'll hopefully pilot the intervention. It's hard to say now how that's going to go with everything else going on. The other barrier we found is, I think that maybe Heather talked about this too, but is that idea that people don't always want to accept help. So we've gotten some funding from Siren, examining why people decline assistance. And just on this side of the mountains, through Rocky Mountain health plans, about half of people decline outright. So they check a box on the screening form saying, please don't contact me. And then of the people that say you can contact me, case managers are only able to reach about half of those people. So we're really, there's a big gap in identified need and then attempts to connect people with services. So the project that we're working on is using a 3-step process to look at why this might be, to then engage the community around solutions and to test those solutions. So as far as advice for clinics, I think Heather gave a lot of good advice for the clinics, but I'll just repeat, find a champion. I think that's what the person who runs this project at Rocky Mountain Health Plans feels is important. Easy process and streamlined process. And then you really have to make sure all are on board, but then some are responsible. And then researchers, I think there's lots of interesting questions coming out of this. So considering the effects of screening and recording on equity. So there's concern that when we start to identify these needs, we may introduce bias, implicit bias into our thinking about patients. There's a lot of unanswered questions. So will providers change their medical recommendations or care based on what they know about the patient's social needs? For example, if you know that someone, is having trouble affording food, will you make a change, like maybe the wrong medical decision about what you might prescribe or recommend to them? Will we make assumptions about how people are caring for their families? Sort of that idea of not wanting to say that they don't have food so that protective services isn't called. And then will patients experience stigma or discrimination? And all of these things I think are interesting things to consider as we move forward. And that is all I have.
All right, thank you, Anne. Just a reminder to everyone, please keep coming with the questions in the chat. Anne, we had a clarifying question about the Community Resource Network. Can you just speak for a minute about what that is and whether it is an IT system, a commercial product, a community network? What is that Community Resource Network you talked about?
So it's being developed by Quality Health Networks, our regional health information exchange. And so will, I think, ultimately be a commercial product. I think that's what they have in mind. They're using a software developer to tailor the product to what they're looking for.
Okay, thank you. And now we'll hear from Dr. Huebschmann. So I'll let you take it away, Amy.
Okay. Can you all hear me?
We can.
Okay, super. So I'm going to take a slightly different perspective to focus a little more on the research, really unpacking some of the issues that were just brought up by Heather and Anne, especially around discrepancies between positive social determinant screens and interest in assistance. This is all from the patient perspective. Okay, good. This is work that was funded by the Commonwealth Fund and done in 2018. It was led by the University of California, San Francisco SIREN program, Amelia DeMarquis with that group. And I'm attributing many of these slides from work that Dr. DeMarquis presented at NAPCRG last year. Our University of Colorado Internal Medicine Clinic site, where I practice, was one of the 10 sites for this study. All of the sites were clinics that had not previously conducted social determinants of health screening or were naive to that type of screening. So as has already been addressed, there's been a great policy push for social risk screening or social determinants of health screening in healthcare. There's been interest in this inequality between people who screen positive for social risk and those who are interested in social care assistance, as was already brought out by Dr. Bleacher. Some studies have shown these are completely discrepant. Some say that's much more overlapping, kind of depending on what the risks are. And so this messy middle, we're interested in, what sort of determines where there's synergy, and when people screen positive, they also want assistance or not. One of the questions is, to what degree is this showing a lack of acceptability of social determinant screening, and sort of brought out some reasons why people may be finding it unacceptable. So the specific aims that I'm going to present data on today are within these 10 diverse primary care and emergency care health systems, caring for a majority of patients who either had Medicare or Medicaid funding. So we wanted to do an underserved population to determine the acceptability of healthcare-based social determinants of health screening, and also the frequency and predictors of interest in risk assistance for those who screen positive or those who screen negative. These were the elements we thought we hypothesized would be associated with acceptability and also would be associated with interest in assistance. So on the left-hand side, a greater burden of social risks, prior exposure to social risk screening, or a sense that this is normative or reasonable to be done in healthcare, trust in the provider, and being part of a safety net system. We thought all those would increase the acceptability and increase the interest in assistance. And we hypothesized that past discrimination in healthcare settings would be negatively associated with interest and acceptability. As was already addressed by Anne, we were using the Centers for Medicare and Medicaid Accountable Health Communities National Demonstration Risk Screening tool. So this is the same tool that she mentioned as being done in Western Colorado with the Rocky Mountain Health Plan. And so I've showed visually those domains that it addressed: housing, transportation, utilities, food, and abuse. And basically for this study, we had the participants did the screening tool. They answered these questions, and then they were asked about their interest in assistance for these questions. And they were also asked subsequent other questions about how they felt about being screened and how they found it acceptable or not. There was also a qualitative study that I'm not going to go into in depth today. So I'm showing here, Anne already showed this slide for the blue circles, which were the sites doing the accountable care, doing this 10-item survey as normal care, at least within the clinics that agreed. And I'm showing the green stars and red stars as the regions, the clinics and emergency departments that we were undergoing this work with for this study. So in terms of aim 1, the survey measures of acceptability, after they had already completed the tool, we asked them these questions. Do you think it's appropriate to be asked these questions about your social and economic needs at this clinic or this emergency department? And also, would you be comfortable having these kinds of needs included in your health record, medical record, or chart? In terms of those who we surveyed, we assessed 1,771 people for eligibility across the 10 sites with the goal of enrolling 1,000 people across the 10 sites. Most of those who declined just really didn't even hear about the study. This was mostly a convenience sample in waiting rooms of clinics and emergency departments, so a large number of those declines didn't go through the process of hearing much about the consent. Those who did begin the survey, the vast majority completed it. In terms of demographics, it was majority female and adult patients. In addition to the 78% adult patients, 22% of the sample were caregivers for a pediatric patient. There was a little over a third of folks below the federal poverty line who were answering these surveys, large number of Spanish speakers, and a diverse population for race and ethnicity. For aim 1, the result, over 80% of those in primary care and 3/4 of those in emergency departments agreed that this type of screening is very appropriate or somewhat appropriate. It was only 7% who felt this screening was inappropriate. Then, interestingly, a decrement in those who were comfortable having this information in their record. So 20% of those screened reported being uncomfortable with this being recorded in the electronic health record. Of course, this is poses a bit of a logistical issue for us in clinics, as generally that's exactly where we're putting this information when we screen patients. This is a multivariable model of things that were related to acceptability. So as we had predicted or hypothesized, prior social risk screening, being surveyed in a safety net setting, having reported complete trust in their clinician, these things were all significantly associated with acceptability. a report of prior healthcare discrimination made people less likely to report this was acceptable, and prior assistance with social risks also increased the acceptability of having the data reported in the electronic health record. This is in terms of our AIM2 data, so comparing those who had a positive social determinant screen with those who were interested in assistance. You can see here, again, large numbers of people, as reported by Anne and Heather, were screening positive for social risks. And on the lower section, we can see that 65% of people had at least one risk. There was only 35% with no risks. In terms of interest in assistance by screen, to orient you to this slide, so going along the x-axis, we have the number of positive social risk domains, or how many things they screened positive for. There were only 5 domains in the survey, so that's the maximum number they could have screened positive for. And then the red bars are the interest in assistance. So over here with 0 positive screen domains, still 9% of people were actually interested in assistance. So this would have been a false negative screen. So people actually did have needs they wanted to attend to. Then amongst those who had 1 positive screen, almost a third were interested in assistance. And as the number of positive screens goes up from there, you can see greater interest in assistance, a dose response, if you will. This slide is showing those who screened positive and then those who screened negative and their interest in assistance for each specific type of domain. So you can see amongst housing, it was 37% who screened positive, only 8%, and those who screened negative, 8% wanted assistance. For food insecurity, 35% of those who screened positive wanted assistance, 4% of those who screened negative still would like assistance. You can see the difference here that 30 to 40% of those with housing, food, utilities, and transportation were interested in assistance. Of those who screened positive, a much lower number for personal safety, interpersonal violence. This is our multivariable model of things that were associated with interest in assistance. So as I showed on that dose response slide, the number of social risks, as that increased, there was greater interest in assistance. Race was significantly associated amongst those who screened positive. Low income was a contributor. This I find really interesting. It's not a really strong odds ratio, but those who answered questions about interest in assistance first, we randomized the order. So some people received the questions about interest in assistance before they received the social risk screening. And that was significantly associated with people screening positive and being interested in assistance, suggesting perhaps that knowing the types of assistance available or that there would be assistance available makes a difference in how people answer the screening questions. Amongst those who screened negative, so they had a false negative but still were interested in assistance, some of the same things were applying here. So low income was strongly predictive, as well as people being in fair to poor health were more likely to be interested in assistance even if they had screened negative and a prior screen for social risk. This was a cross-sectional study, only those who read English and Spanish, only 10 sites, but across the United States. And they were asked about acceptability and interest in assistance as part of a research study while they were presenting for clinical care, but it wasn't necessarily part of that clinical encounter. So my conclusions from this research is that acceptability of social determinant screening in healthcare settings is very high amongst patients, but a significant minority would not want the answers recorded in the health record. There being congruence between those having a positive screen and also being interested in assistance is higher amongst those with multiple social needs. There's a dose response that we've seen there. Those with lower income and those asked about interest in assistance before being screened for social risks. I think that latter piece may have practical implications for clinics that are looking at doing screening to potentially ask about interest in assistance in combination with the screening for social risks. And we are more likely to miss if we don't explicitly ask about interest in assistance. Those who are interested in assistance, even though they would screen negative, are those in poorer health and of lower income in particular. So I've listed the future directions here. Also in terms of tools, the UCSF Siren Network has excellent resources for implementing screening on their website, including a list of different screening tools that are well validated. They also do a free monthly e-newsletter where they keep people up to date on what's going on in the field of social determinants And the myownhealthreport.org site also has an integrated behavioral health risk assessment and social determinants that includes some potential options for assistance along with the screening, or does those in combination. I want to thank the research team, the sites, and list my information there. Thank you very much.
Thank you, Amy. So I am going to go through and address some of the questions that people have been sharing on chat as we've been talking and listening to our presenters. So I'm going to start with a question for you, Amy. Christina Stutz asked, is trust in provider as you screen for it, referring to the physician or to others involved in the screening and linking to resources, or for the practice at large? So can you speak a little bit about that trust in provider metric?
Yes, thank you for the question, Tina. I'd have to look back to remind myself, but my recollection is that it was specifically about trust in one's clinician. So it didn't necessarily have the umbrella and the person asking the questions or near them as this was a self-administered survey on a tablet, but who was around them obviously was not, included in that umbrella. I will say that in the qualitative work we did, it did come out quite a bit that how the question was asked and whether the person really seemed interested in their response or was just checking a box to say these questions, people noted that was a part of how they would feel comfortable answering the questions or not. So that does indicate some level of issue of trust, so to speak, in the person also doing the screening.
And I think this question was directed at Amy, but I think all three of our panelists can probably speak to the comparison between population level social risks and the data that you've collected in your clinical settings, and whether these compare to sort of the general population in any particular way.
So this is Anne, and I had answered in the chat that for the population in Western Colorado, these rates are higher than what's found in the average population across the US. The only one I can tell you numerically is that pre-pandemic food insecurity, sort of all comers across the US, was around 11%. So obviously that number that we have found in screening is much higher than that. I did want to just add that I saw something that Elena shared with me yesterday, that someone just surveyed a sample of people across the country, and those rates have just skyrocketed since the stay-at-home orders and jobs have been lost with the pandemic. So a lot of these things that we're looking at just fluctuate quite a bit. So looking at a rate without the context might be hard anyways, but yeah.
Heather or Amy, did you want to add anything around the general population rates versus what you saw in your work?
I don't have specific statistics to share. I was just trying to scan quickly to see if Siren had anything on their website or what else I could find. Heather, do you have other information?
I don't know, unfortunately.
Well, Anne, I think you raise a really important point, and it's something we knew was going to come up today, but what are you guys thinking about how we either shift social determinants of health screening, or what impact COVID and the pandemic really have on how we do screening and how we address patients' needs?
Well, I think there's two sides to that. I know the clinic that I do my clinical work in has had to take the staff that had been doing the social determinants screening and have them help people get on telemedicine and figure out how to use that from home. So I think it's possible that what's happening will cause a decline in screening, plus people are not, going into primary care as much. So there's that issue, but also then the other side is I think there'll be a huge increase in needs, and a lot of these things take a long time to recover after an economic hit like we're seeing now. For example, the food insecurity rate really increased with the recession in 2008. I think it went from about 11 where it is now, or not even now, but a month ago was, to close to 18%, and it took a decade for that to come back to the pre-recession levels. So I think really, you know, we need to make sure that we keep this issue on our minds despite how pressing the pandemic issues or the infectious disease issues are. I think that this whole situation is going to increase the need and may require some other avenues for screening besides at in-person visits.
This is Heather. So, you know, my take on this is, you know, as I mentioned at the beginning of my presentation, our formal screening process is largely defunct at this point. But I do think it's very natural for people who are seeing patients virtually or even in person to kind of check in and see how people are doing. I get the sense that these sorts of issues may come up more organically just through clinical care, because it's at top of mind. And so I guess I would say, you know, if you don't have a formal screening process in place currently, just thinking about how you can ask these kinds of questions in an open and non-judgmental way that people are likely to respond honestly to, and be forthcoming about, and not be embarrassed about. The other thing is I've just, as of yesterday, I've been emailing with some other folks in the committee that spearheaded our screening initiative. And we are thinking a little bit more about social isolation and how that is going to be, and is like a huge factor in how people have access to food and their medications and all of those things. So we are thinking about how we can generate a list of some of our more medically complex patients and outreach them in a systematic way to see what needs they have and if they need to come in, or if there's anything we can do to assist them.
Okay. Amy, did you want to add anything?
I think that was well addressed. Thank you.
Yeah. So Heather, we got a couple of questions about some of the discrepancies in screening by race and insurance type. Can you speak a little bit to any plans or potential interventions to address those screening inequities, and also whether you have any indication of whether certain groups were more or less likely to decline referrals based on their screening?
Those are good questions. So in terms of whether folks were more or less likely to decline help based on race or ethnicity, I'm trying to like scan my data at the same time, but I'm not going to be able to talk and scan at the same time. So I'll have to take a look at that and then chat back out. In terms of like what to do about it, you know, I think the first question is like, why is it happening? I don't really know. My guess off the top of my head would be that people of color and people on public insurance are groups that potentially experience more stigma in general life, and so may have been more sensitive to the personal and potentially stigmatizing nature of the questions that we were asking, increasing their hesitancy to answer. But I'm sure it's more complex and nuanced than that. So, you know, we are not currently acting on it at this time, but I think it's an area that's ripe for investigation and research, to be sure.
Great, thank you. And we had a question from David Allward. How much of the reticence to accept help might go away if the person dealing with the patient is a near peer or someone with that lived experience, like a community health worker or an MA from the community? Can you speak to that?
Sure. I mean, I think that that's a really good question. And I didn't go into all the details of this, but what we found in the study we did last year really was that there's more within group stigma than necessarily that perception of stigma by healthcare workers. So I'm not sure. I mean, I think, you know, it was really interesting that we also looked at who had experienced food insecurity in the past in their lives, and whether that, well, we couldn't really associate whether that affected their responses, but medical providers were the least likely to ever have had lifetime food insecurity. Community-based organization staff and community members actually were pretty close. There was almost all of the community members had experienced it, but a vast majority of the people who worked for community-based organizations had. But yet those were the two groups that we saw say people used services that didn't really need them, or sort of attribute things like I mentioned before, like laziness or not wanting to have a job or being irresponsible with the reasons why you might end up facing food insecurity. So I think it's a good question. Like, logically, it seems like that would be a good approach, but I'm not sure. And that's really what we're hoping to explore with this project through Siren too, is, would there sort of who asked the questions, how that's handled, does that make a difference as far as acceptance or people feeling comfortable with the screening process and referral?
Thank you. Well, we are down to our last minute. I want to thank Amy and Heather and Anne all for sharing some of the work that they're doing in various communities. I do want to point out there are a couple of questions and resources that have just been shared in the chat. So if anybody is interested in those, please take a look before you sign off. Just a couple last things before we all log off. You should be getting an evaluation after this, so please fill that out. That helps us to make sure we're doing a good job. And then second, just a reminder that on April 28th, we have Susan Jack's talk at noon, and on 5/11, Don Neese will be presenting around engaging the community in researching social determinants of health. So thank you, everyone, for joining us today, and I hope you all have a wonderful Wednesday.
Thank you.
Thanks.
Thanks all.